Welcome to this session on managing difficult airways, a vital skill for anesthesia, emergency medicine, and critical care professionals. A difficult airway occurs when mask ventilation, tracheal intubation, or both are challenging, and the stakes couldn't be higher. Mismanagement can lead to hypoxia, brain damage, or death. The ASA Closed Claims Project highlights this, showing airway issues account for up to 30% of anesthesia-related malpractice claims, making preparation essential. That's where the 2022 ASA Difficult Airway algorithm comes in. It's a structured decision-making framework designed to guide us through these high-stakes situations, ensuring we're proactive. The algorithm starts with assessing risks, like difficult ventilation or laryngoscopy, and helps us choose between awake or asleep intubation, always with a plan in place. It emphasizes having backup strategies, like switching to video laryngoscopy or preparing for a surgical airway, so we're never caught off guard. As a general rule, treat all intubation attempts as potential difficult airways. This mindset pushes us to always have a plan and a backup. But a plan is only as good as the team executing it. Clear team communication is vital. Before you start, huddle with your team. Who's the primary airway manager, what's the backup plan, and who's on call for help? This ensures everyone's aligned and ready to act. Remember, preparation and teamwork save lives. Today, we'll dive into the algorithm's details, real-world cases, and why planning and communication are non-negotiable. Let's get started. Here's a bird's-eye overview of the ASA Difficult Airway algorithm for adult patients. At first glance, it might look chaotic with all its boxes and arrows, but don't worry. We can simplify it by breaking it down into three main sections. First, we have the pre-airway management decision-making tool. This is where we start, asking key questions about the patient. Is there a suspected difficult laryngoscopy, difficult ventilation, a high risk of aspiration, or rapid desaturation? We're evaluating anything that might make airway management tricky. Based on these answers, we decide whether to proceed with the patient awake or after inducing anesthesia. Second, there's the awake intubation path. If the assessment flags potential difficulties, we might opt to intubate the patient while they're still awake. It's a safer choice in some cases, and if it works, great. If not, we explore other options. Third, we have intubation after induction. This is the more typical route. Induce general anesthesia first, then attempt intubation. If it fails, the algorithm guides us on what to do next, depending on whether we can ventilate the patient with a mask. Beyond these sections, the algorithm also covers what happens if intubation fails, splitting into non-emergency or emergency pathways based on ventilation. It's a detailed guide, but these three parts, pre-intubation assessment, awake intubation, and intubation after induction, form its backbone. And of course, clinical judgment is key in applying it to real patients. Let's go back and talk in more detail about the pre-airway management decision-making. The pre-airway management decision-making tool focuses on the initial decision between awake intubation and intubation after induction of general anesthesia. This is a crucial choice, as it sets the stage for the entire airway management process. The goal of your initial assessment is to identify risks early to tailor your plan, whether it's awake intubation or having specific tools at bedside to help secure the airway. Clinical judgment is also important, as the final decision rests with the airway manager based on their experience and the specific context. Your assessment ensures you're ready before the airway fight begins. Having a plan and knowing what you are going to do next if your first plan fails is vital. When it comes to any airway, easy or difficult, the pre-procedure assessment is crucial. Start with a thorough history if able. Ask, have you had trouble with intubation before? Past difficulties, airway surgeries, or neck radiation are red flags. Based on your history and physical assessment, are there concerns for difficult intubation? Remember the lemon criteria discussed on a prior video? This is where everything you've learned is put into practice. Will there be difficulty with patient cooperation or consent? Do you anticipate ventilation challenges with a face mask or supraglottic airway? Do you anticipate difficult intubation based on exam findings? Is there an increased risk of aspiration or rapid desaturation? Would an emergent surgical airway be challenging due to neck pathology? If so, an awake intubation might be warranted. Choosing an awake approach helps keep the patient breathing, reducing risk of intraprocedural decline. Airway management after induction is by far the more common approach for patients without predicted airway difficulties. However, if initial attempts fail, there needs to be rapid reassessment, including calling for help, attempting to restore spontaneous ventilation, or awakening the patient, which we will discuss further in a later slide. Now let's talk specifically about awake airway management. Awake intubation remains a cornerstone for predicted difficult airways. If preoperative assessment demonstrates risks, like limited neck mobility, history of difficult intubation, concern for difficult ventilation after induction, increased aspiration risk, or intolerance of brief apnea, awake intubation should be considered. Techniques include fiber optic bronchoscopy for tricky anatomy or video laryngoscopy for a clear view while the patient's conscious. The ASA cites observational studies showing awake fiber optic intubation succeeds in 88 to 100% of difficult airway patients, solid evidence of its reliability. Preparation is key. Light sedation with Versed and fentanyl, ketamine or dexmedetomidine keeps them calm but cooperative, and topical lidocaine should be used to help anesthetize the airway. If an awake intubation attempt is unsuccessful, you should take a step back and quickly decide what to do next. Is the patient stable enough to postpone the intubation? Do you need to consider a different intubation technique or utilization of additional tools you have at your disposal, such as a bronchoscope or bougie? Will an awake elective invasive airway be the best approach? Do you need to use different sedation or anesthetic techniques to help sedate the patient or better anesthetize the airway? If the patient is unstable and it can't be postponed, induction and preparation for emergency invasive airway may be needed. The third part of the algorithm deals with airway management with induction of anesthesia and provides a detailed guide for managing the airway once anesthesia has been induced. The two images are the same, presented differently. The image on the right shows the fluidity between the non-emergency and emergency pathways. Let's dig into this a little deeper. The process begins with reviewing the airway management strategy and pre-oxygenating the patient throughout the procedure. This is where our prior discussions on pre-oxygenation and apneic oxygenation are utilized. After induction, the clinician assesses whether the airway plan was successful. If yes, continue as planned. If intubation was not successful, you must evaluate ventilation adequacy. If ventilation is adequate with bag mask, the algorithm directs to the non-emergency pathway, where alternative devices and techniques can be employed to secure the airway, with a focus on limiting attempts and avoiding task fixation, meaning preventing an excessive focus on a single technique at the expense of situational awareness and patient safety. At this point, it's important not to panic and remember, the patient is oxygenating and ventilating adequately. Consider the other tools at bedside, such as video laryngoscope, bougie, or bronchoscope. If ventilation remains inadequate, use a supraglottic airway. If ventilation improves, proceed to the non-emergent pathway and secure the airway. But again, it's probably not best to repeat the technique that's been attempted and failed. If the first attempt was with direct laryngoscopy, then use video laryngoscopy. If the initial attempt with video laryngoscopy was not successful, consider video laryngoscopy with the addition of a bougie or bronchoscope to help secure the airway. If ventilation still remains inadequate despite bag mask or supraglottic airway, the emergency pathway is activated, which involves calling for help and preparing for an invasive airway. At this point, I want to circle back to re-emphasize the importance of avoiding task fixation and becoming hyper-focused on the same technique over and over. When things do not go as planned, it's important to maintain situational awareness, tracking time, attempts, and oxygen saturation to prevent complications and further airway injury. Limit the number of attempts for each approach. Having a clear plan for escalating care, including the use of invasive techniques if necessary, will help you maintain focus during the emergency. Now that we've explored each algorithm individually, let's discuss how they integrate into clinical practice. These algorithms are designed to be used in conjunction, providing a seamless flow from pre-procedure assessment to procedural management. A recurring theme is the importance of team communication and planning, especially in emergency situations. This should happen before you do anything. Pre-procedural preparation is key. A pre-procedure checklist can be used to make sure all needed equipment is available. The image on the screen is an example of a checklist that can be utilized for preparation. Clearly identify roles so there is less confusion if an emergency occurs, such as who is getting equipment or who is calling for backup. Clinicians should call for help early and ensure that all team members are aware of the plan and potential contingencies. Adaptability. While the algorithms provide a structured approach, they also allow for clinical judgment. Notes throughout the charts remind clinicians to consider patient-specific factors and to adapt the strategy as needed. In practice, these algorithms should be familiar to all team members, and regular simulation training can help ensure that everyone is prepared to execute the plans effectively. The emphasis on limiting attempts and being aware of time and oxygen saturation is also crucial for preventing complications and ensuring patient safety. Now that we have reviewed the ASA Difficult Airway algorithm, let's review available tools that can be used when standard intubation fails. The 2022 algorithm update emphasizes video-assisted laryngoscopy. Meta-analyses show video laryngoscopes like GlideScope or CMAC improve laryngeal views and first-attempt success in difficult airways, with Category A 1B evidence. The guidelines also highlight their equivalence to flexible scopes in some scenarios. Supraglottic airways like the LMA or iGel, as seen in the top left of your screen, remain lifesavers for ventilation. Observational studies report a 94.1% success rate for rescue ventilation when mask ventilation and intubation fail. Moving to the top right, bougies and stylets guide tubes in tough cases, with 78 to 100% success rates. These can be utilized with video laryngoscopy. Once the laryngoscope has been inserted, the tool is inserted and advanced into the trachea. An endotracheal tube is then loaded onto the bougie and can advance into the trachea over the tool. Fiber optic scopes, seen in the bottom left, are great for awake or asleep intubation. Before starting, an endotracheal tube is loaded onto the bronchoscope before insertion. The scope is navigated to the trachea. Once in the trachea, the tube is advanced over the bronchoscope and into the trachea. The scope is then removed. Finally, surgical airway kits, as seen in the bottom right image, are your last resort. The ASA guideline stresses identifying alternative approaches if your primary plan fails. It's also important to consider that these tools can be used in combination, such as using a flexible scope through a supraglottic airway or utilizing video laryngoscope while intubating over a bougie or bronchoscope. Practice these tools. Know their strengths and limits. The ASA's evidence-backed recommendations ensure you've got options when the airway fights back. Now let's apply the difficult airway algorithm to a case. A 55-year-old male, BMI 35, with a history of neck radiation, presents for a thyroidectomy. Assessment shows Malampati 4 and limited neck mobility, clear red flags. The 2022 algorithm guides us step by step. Step 1. Assess the likelihood of respiratory decline with intubation. Obesity and neck radiation suggest difficult mask ventilation and supraglottic airway placement due to soft tissue and scarring. Limited neck mobility flags difficult laryngoscopy and intubation. The new decision tree prompts us to consider awake intubation if there's difficult ventilation, which applies here. Step 2. Pursue supplemental oxygen. We ensure nasal cannula oxygen is on. Step 3. The algorithm's decision tree indicates awake intubation as the safest choice, preserving spontaneous ventilation. We choose fiber optic bronchoscopy, as the ASA notes its 88 to 100% success rate. We sedate lightly, apply topical lidocaine, and proceed. The scope navigates the distorted anatomy, we place the tube, and capnography confirms placement, per ASA recommendations. This case shows how the 2022 updates, especially the decision tree, help us preemptively choose awake intubation, ensuring safety in a high-risk elective surgery. Preparation turned a potential crisis into a controlled procedure. Now, an unanticipated difficult airway. A 30-year-old female trauma patient needs an emergency laparotomy. We proceed with RSI after a quick assessment. No major red flags, but direct laryngoscopy fails. I can't see the vocal cords. Let's use the airway management with induction algorithm. Step 1. Identify the problem. Difficult laryngoscopy and intubation. The algorithm asks, can I ventilate? Yes? Bag mask ventilation works, keeping SATs at 95%. Step 2. Optimize oxygenation. We're delivering oxygen via mask, buying time. Step 3. The algorithm directs us to alternative approaches since the primary method failed. The 2022 updates emphasize video laryngoscopy's higher success rates, so we grab a glide scope. We reposition, use the glide scope, and now the cords are visible. Tube goes in on the second attempt. Capnography confirms placement, as the ASA mandates. This case shows the algorithm's strength in surprises. Recognize the issue, stabilize with ventilation, and pivot to a proven alternative. The 2022 focus on limiting attempts and using evidence-backed tools like video laryngoscopy turned a chaotic moment into a success. Here is another case example of unanticipated airway challenges. A 45-year-old overweight male arrives to the ICU with respiratory failure and altered mental status, so we opt for intubation. Direct laryngoscopy is attempted first, but the anterior airway blocks vocal cord visibility. Attempt 1 fails. Bag valve mask ventilation struggles, so we place an LMA, which stabilizes him with good airflow. Next, we switch to a glide scope, but the anterior airway still complicates tube placement. With the LMA holding strong, we grab a bougie, thread it through, and secure the tube. Airways locked in, confirmed by capnography. This ties to the ASA algorithm. Spot the issue, ensure ventilation, then adapt with tools like the bougie and glide scope. It's a real-world win driven by quick, evidence-based shifts. This last case is an example of a critical emergency. A 45-year-old male with severe angioedema, likely from an allergic reaction, rapidly desaturating in the ED. We induce to secure the airway using video laryngoscopy. Time's critical. But video laryngoscopy fails due to swelling, and mask ventilation doesn't work. SATs drop to 55%. We're in a can't intubate, can't ventilate crisis. Let's apply the algorithm. Step 1. Identify the problem. This is the life-threatening can't intubate, can't ventilate scenario the algorithm prepares us for. We're facing difficult laryngoscopy, intubation, and mask ventilation. Step 2. Supplemental oxygen attempts fail. Mask ventilation isn't effective. Supraglottic airway device isn't an option due to significant airway swelling. Step 3. The algorithm directs us to invasive techniques when all else fails. Surgical airway. We locate the cricothyroid membrane, perform the incision, insert a tube, and connect to ventilation. SATs climb to 90%. The airway's secured, and we stabilize him for ICU. This case highlights the 2022 algorithm's clarity in a crisis. Identify the can't intubate, can't ventilate scenario, escalate to a surgical airway, and act swiftly. The emphasis on oxygen delivery and situational awareness, tracking SATs and time, was key, as was having a cricothyrotomy kit ready. While the ASA algorithm is our primary focus, other difficult airway algorithms offer valuable perspectives. The Levitan algorithm emphasizes the intubation route and RSI contraindications, like oral pathology such as angioedema, guiding when to avoid RSI and opt for awake techniques. The Strayer algorithm compares RSI versus awake intubation, favoring awake for less urgent cases with difficult airway features and low vomiting risk, providing a decision-making pivot. Wall's algorithm, often used in emergency settings, offers a structured approach for rapid airway management, especially in trauma. The Vortex algorithm is a visual cognitive aid. Its funnel design escalates from basic maneuvers like positioning to advanced techniques like LMAs, ending at surgical airway for can't intubate, can't ventilate scenarios. The Difficult Airway Society provides comprehensive guidelines, particularly for unanticipated difficult intubations, integrating multiple pathways. These algorithms complement the ASA's framework. Levitan's focus on RSI safety, Vortex's visual clarity in crises, or Difficult Airway Society's broad strategies. While we've centered on ASA for its evidence-backed structure, exploring these others can enhance your toolkit, especially in varied clinical contexts. Let's recap the key takeaways from our discussion on difficult airway management. Difficult airway management is a critical skill that requires thorough preparation and a structured approach to ensure patient safety. The 2022 ASA Difficult Airway algorithm provides a comprehensive framework for decision-making, from the initial assessment to intervention, and is an essential tool for clinicians. Pre-procedure assessment is crucial for predicting potential difficulties and tailoring our approach accordingly. For predicted difficult airways, awake intubation is often the preferred method, allowing us to maintain spontaneous ventilation and minimize risks. Team communication and preparation are vital. Using checklists, defining roles, and ensuring everyone is aware of the plan can make a significant difference in outcomes. Familiarity with various airway tools, such as video laryngoscopes, supraglottic airways, and bougies, is essential. Knowing when and how to use these adjuncts can be life-saving. Through case studies, we've seen how the algorithm can be applied in real-world scenarios, reinforcing the importance of adaptability and quick decision-making. Proactive planning is non-negotiable. Always have backup strategies ready and ensure your team is prepared to execute them. Integrating knowledge from prior learning enhances our capabilities. Understanding airway anatomy helps us anticipate challenges, while assessment techniques aid in prediction. Recognizing indications for intubation ensures timely intervention, and selecting the right equipment can influence success. Techniques like pre-oxygenation and apneic oxygenation extend safe apnea time, and mastering rapid sequence intubation is critical for at-risk patients. As we conclude, remember that as medical professionals, our skills and preparedness can make the difference between life and death. We are guardians of the breath and keepers of possibility. The 2022 ASA algorithm gives us the tools to turn chaos into control, but it's our skills and preparedness that determine the fragile boundary between a patient's next breath and eternal silence. Let's commit to excellence in airway management, continuously refining our abilities and staying vigilant in our practice. Thank you for your dedication to this critical aspect of patient care. For deeper dives, check these references. The 2022 ASA Practice Guidelines in Anesthesiology. It's the full text, packed with evidence, linked on PubMed. The Anesthesia Patient Safety Foundation's update offers a practical breakdown, perfect for quick reference. Life in the Fast Lanes blog covers other algorithms we touched on, adding real-world insights. Keep these handy. They're your go-to at 2 a.m. when puzzling out a tough airway. Thanks for listening.